me.
Dave, you're live. Go.
Yeah, but it won't let me. Is it working? Hello, can you hear me?
Dave.
All right. It's in order for me to do it, I have to stay on this screen, so I don't know who else is on. Is it?
You're live?
Is it working? We'll
Yes.
see. And I swipe over here, and it turns off the micro.
Yep, you're good.
So I have to just stay on this one.
Yep.
Yay. Okay. Take your stuff.
You're recording right here.
Good morning, everybody. It is Thursday morning again, and I am 5 minutes late, but that's because I have absolutely no technological knowledge. I have no idea how to make these things work. Today's webinar is about orders, and I know you guys are going to start getting sick of hearing about orders, but until y'all start doing them right, I'm just going to keep preaching, because fixing the orders is 10 times harder than you actually doing them correctly. There are 3 types of orders in the Care Anywhere Brightree system. There are plan of care orders, there are verbal orders, and there are written orders. I'm going to go over each one, explain what each one is used for, and explain how to do them and how to put them in properly so that it just, number one, makes sense, but number 2, meets the guidelines that we have to follow. Plan of care orders are basically that. They are orders that are put in upon starts of care and recertifications only. Because they will be put on the plan of care that goes to the doctor for signature. So if the nurse opens the case, does the initial admission, all of their orders are obviously going to be start of care orders, including the meds, the standard orders, frequency orders, treatment orders, and everything like that. If PT, OT, speech, medical social worker are also evaluating based on the new start of care, all of their orders will go in as plan of care orders. And then again at recert, whoever does the recertification, their new orders, their new frequencies, any new treatments, any med changes will go in as plan of care orders because they're going to go on the new plan of care. If nursing is doing the recert and physical therapy has done a reassessment and plans on continuing into the new cert period, their orders also will be plan of care. Now again, you still have to call the doctor at the start of care and the recertification if you are planning on continuing to treat, and have documentation that I have notified the physician, this is what we're going to do and this is what our frequency is going to be. We still have to have that verbal communication with the doctor approving it before we make any more visits. The only other time a plan of care order is used, and this is the only other time, is if the patient is transferred into a facility like a hospital and outpatient rehab. Anytime the patient is put in transfer hold, the plan of care order type is used to discontinue the frequencies that are already put in place. The reason being is if you put him in as verbal, the doctor's going to say, well, I didn't tell him to go to the hospital, I'm not signing the order. And if you put him in as written, we don't have a written order to attach to the chart to say this is that it's written. So plan of care is the only one that makes sense. So when you're discontinuing a frequency order because they went in the hospital, you choose plan of care type, but you also have to put underneath it the reason, patient is hospitalized. So again, plan of care, starts of care, and recertifications only. Written orders. Written orders are anything that we get from the doctor's office, wound care centers, or anything that is already written with a doctor's signature on it. Not a nurse practitioner's, not a physician assistant's. It actually has to have the doctor's signature. And it can say electronically signed by Dr. So-and-so, but it cannot be signed by a nurse practitioner or a physician assistant. So when I get orders from the wound care centers saying, this is what we're doing, this is what we're changing, in the office, we put them in as written orders because I have something in front of me that says, change this by this doctor, and he signed it. If you get something written, because a lot of times you will go to the patient's home and they'll hand you a prescription slip that says, draw blood work on next visit, and it's signed by the doctor, that is written, and you have to bring that prescription slip in so we can attach it to the chart. If you get it and it's signed by that doctor's nurse practitioner, then it has to go in as a verbal order from the doctor that signs the nurse practitioner's orders. And on the verbal order, you need to put per prescription or per written order from nurse practitioner. That'll explain to the doctor why they have to sign it when the nurse practitioner already did. That can get a little confusing, and I'm sorry, but it's a regulation. We have to have a doctor's signature. We cannot accept nurse signatures in the home health setting. We can take an order from them, not a problem. A nurse practitioner can call and say, I want you to do this, this, and this. That's fine, that's great, but it's got to go under the doctor who signs your orders. Written orders are also used for any medication changes. If you get to the patient's home and they went to the doctor the day before and you said, so did he change any of your meds? And they pull out 2 pill bottles and say, these are my new medicines. Those are written orders because the doctor has already written the prescription. We didn't get a copy of it, but the pharmacy got a copy of it. And they filled it and put it in. And now you have basically the written order sitting on the pill bottle, because it will tell you what the med is, the dosage and everything, and it will have the doctor's name on it that prescribed it. If it's a nurse practitioner that prescribed it, it's still considered written, just under the doctor that signs for that nurse practitioner. So any med changes like that, they have to go in as written. The only time medication changes wouldn't be written, the easiest example is a Coumadin dose change. If you check a PTINR and you call the doctor and they say, well, tell them to stop taking 5 milligrams, tell them to only take 2.5 milligrams, that's a verbal order because we are verbally getting the change of dosage and the bottle itself is not going to change. The bottle itself, especially with Coumadin, pretty much says these are 5 milligram tabs, take as directed. So that will be a verbal because the doctor is giving the directive on changing it and everything like that. Also, if you call a doctor, a patient's blood pressure is through the roof, and you call the doctor and they say, all right, I want them to take their Lasix twice for the next 2 days, that's a verbal order. That is a verbal medication change because the pill bottle itself, again, is not going to change. They're not going to write a new prescription. They're just increasing the dose at that point. So yes, that would be a verbal order. And when you're putting in a verbal order, you've got to make sure when it pops up and you're choosing verbal order, at the bottom of that little screen, it lists the doctors. You tap on the doctors. You have to choose the doctor that's giving you that verbal order. Because we have a lot of them that the PCP, we've got, the primary doctor is Dr. Miller because it's ortho, but you called the PCP and they're the one that gave you the order. You need to change the doctor to the proper doctor giving you that order. If the doctor is not in the system, call the office, we'll get it in, we'll get it attached to the chart, and then you can finish the order as needed. The last one is verbal orders, and this is the one that we're having a lot of difficulty with, and people are seeming to have difficulty with verbal orders. The main difficulty we're having is they're not choosing the right doctor. So again, if you are doing a verbal order, you've got to make sure you check the right doctor. And when you are putting in a verbal order, there is a box that says, is this read back and verified? You actually can't submit it until you hit yes or no. And I'm praying to God you hit yes, because you should not be putting in a verbal order unless you've actually verbally spoken to somebody. The next thing that'll save you on that is put the person's name you spoke to in the verbal order under the comment section. Because if you call a doctor's office and you're talking to their nurse and they come back and say, yes, the doctor wants you to do this, this, and this, then you put verbal order, you put the order in, you check the box, yes, it was read back and verified, but under the comment section or the other text section, you should put read back verbal order from nurse so-and-so. Because down the road, we send that order to the doctor to get signed, and they're like, I never gave that order. We can actually say, well, talk to nurse so-and-so because she said you gave that order. It saves us. It does. If we know who we spoke to and who gave us the order, we're following directions. If there's a miscommunication on their side, that's their fault. But as long as we do what we can. But again, verbal orders are used for, I called the doctor and they want us to change the wound care. I called the doctor and they want us to increase the range of motion. I called the doctor and, they changed this and this. That is any verbal communication with a physician or a physician's representative giving you a change in orders. You've also got to remember, though, like if they're changing wound care and the doctor says, okay, I don't want you to do that anymore. I want you to do calcium alginate and a dry dressing. You're going to put the new order in. You've got to discontinue the previous wound care order. Discontinue the hydrogel and then add the new order that says calcium alginate and a dry dressing. Whenever you're changing anything, you've got to discontinue the previous. Same thing with the Coumadin orders. If you verbally get a Coumadin order, you need to discontinue the previous Coumadin dose and put it back in with a new dosage and directions. If you're discontinuing a frequency, if we're going from once a day to 3 times a week, you've got to discontinue that previous frequency. And you've got to make sure the dates match up. Verbal orders are also used for resumption of cares. If the patient went in the hospital 3 weeks after we opened them, and they come back out of the hospital a week later, we are still within the current certification period. The plan of care has already been built and sent to the doctor for the signature. So the new orders you're putting in, if you're putting in a new frequency or new treatment orders or whatever is involved for the patient's new condition after coming out of the hospital, they go in as verbal orders to the doctor that is either signing the POC or gave the resumption of care orders. If they're coming out of a hospital and the hospitalist gave us the order to resume care, then you're going to send it to the person signing the regular orders, whoever the primary physician is. They're the ones that are going to have to reapprove, yes, I want you to continue to do this. And you can actually put on the order in one of the orders in the comment or other text section for patients post-hospital. So they understand, why am I getting a new verbal order? I don't remember. But you, again, should be calling the doctor's office and say, I just did the resumption of care. This is the frequency I'm going to do. These are the treatments I'm going to provide, so that we're all on the same page. That communication is key. Especially when we're sending verbal orders to doctors and they're looking at it going, I don't remember giving this order. I don't remember doing this. I don't remember approving this. If you've called them and told them this is what we're doing, then they have record of, oh yeah, that's right. They did call, this is what we're doing. They're more prone to sign it, and we don't have hundreds of orders sitting there because doctors won't sign them. I lost my train of thought. Word of the day is ambiguity. I don't know if I've used that one before or not, but it's just a fun word I'm going to say today. Along with the orders, when you're doing them on the iPad, there are several steps that you actually have to do to make sure the order is complete. And when I mean by complete, it needs to be complete and active before anybody can use it. I've noticed lately a lot of people, they're doing great. They're putting in new medications under written, but they're actually putting each individual medication under a separate written order. So I have gone in, they've left them new, and this is how I catch them. And there's 6 new written orders, all with one single medicine on it. If you're putting in a medication, if you're putting in several medications that are new, and you do the written order, you put the first medication in, then all you have to do at the top, instead of hitting done, you just hit add new, and it brings up another blank medication page, and you just put the next medication in. Same thing as if you're putting in medications, you're putting in the frequency, because this is a resumption of care. Get 3 different places in the chart that you're going to put in different orders. You go under service, discipline orders, you go under other orders, you go under medication profile to put those in. If you put the discipline order in and you've already started it as a verbal order to this doctor, and you go to medications and you hit add new med, the first thing that pops up is at the top. It should give you the order, and it should give you the option to choose the order you've already started. So just choose that, and then everything goes on one piece of paper. So I don't have 15 different verbal orders to send because it was, 10 new meds and 3 new frequent, just make sure they all clump together. After you've got all your meds in attached to that one order, you've got to remember you need to go to your home page on the iPad, and over in the right-hand column, right towards the top, it should say open order. You have to click on that to review it. It's going to pull up, and it's going to show us what that verbal order looks like. You're going to confirm, am I sending it to the right doctor? Are the medications entered correctly? Did I put the frequency in correctly, including the start date? And I'll get to that in a minute. Did I put the new, wound care orders in? Did I discontinue the previous wound care orders? All of that, that's where this comes up, and you just go down through it and check. This is what I've done. This is what I've done. Yes, this is correct. If it is not correct at that point, you can go back into the patient's chart, fix what you need to fix, go back out and review it again. Once you've reviewed it and that is what you want it to say, and this is going to be verbal, plan of care, and written, at the top of it, you can actually hit submit. When you hit submit, it'll change the color of that block. It should be a light gray when you're first looking at it. It'll change it to a darker gray. That means you have submitted it. But you're not done, because you've submitted it and your iPad knows about these orders, but we don't know about them at the office until you sync. Once you sync and your home and your home screen pops back up, that will disappear. Once it's done and it's complete, that little message on the right-hand side will be gone. That means you've done it, you've completed it. Then it comes to us, and then we will more than likely review it to make sure it's truly correct. Okay, as for writing the orders, and this is especially for frequency orders. The first thing you do when you are writing a frequency order, whether it's a start of care order, whether you're changing the frequency in the middle of the certification, any of that, whether it's a plan of care or verbal or written, anything like that, the first thing you do is in your head, I'm going to use the example of we are going from 3 times a week, and now the doctor wants it done daily. All right. So you're at the patient's home, you call the doctor and say, this wound looks terrible. And they go, you know what? I want you to do this, but I want you to do it daily from now on, for the next 2 weeks or whatever they say. What you have to remember is you're going to discontinue the previous previous frequency, and then you're going to add a new frequency order. So this one, nurses are the only ones that usually deal with the daily ones. The first thing you think of is you're going to start the new order as of today. You have to think, well, how many more times today do I need to see them? Well, I've already seen them. They don't need to. So if they don't need to be seen again until tomorrow, that is when the start date of that daily order starts. You change the start date. It's right there. When you're looking at it, you click the start date, you bring it up, you move it to the next day and hit done. That will be the start date for that daily order. If it's weekly, and this is where all the clinicians come in, you need to think, how many more times this week do I need to see them? If you open them up on a Sunday and the week is Sunday to Saturday and they need to be seen every other day, then you need to know, okay, well, they're going to need to be seen Tuesday, Thursday, Saturday. That's 3 more times this week. So your start date for the week can be the day you admit it on Sunday. Same thing with Monday. How many more times this week? Where people are getting a little confused is they do a start of care on Friday. They want them seen 3 times a week, but they don't actually have to be seen again until Monday. So if you're on a Friday and you think 3 times a week, well, how many more times this week do I have to see them? Well, none, because they don't need to be seen till Monday. That's when you change your start date to the Sunday date, because that's the start of the next week. I've had people they need to be seen 3 times a week. They do the start date on Friday, the day they're writing the order. The system is so date specific, it will look for 3 more visits to be made between Friday and Saturday. And, that usually doesn't happen. So you've got to be conscious of how many more times this week do they need to be seen, and if it's ever none or 0, you change the start date to the very next week and then put your frequency in. Monthly back is going back to the nurses. I don't know very many therapists that do monthly visits. That just doesn't make sense to me. If it's a Foley catheter change and that's all we're seeing them for, and all we have to do is see them once a month for the Foley catheter change, then you have to think, how many more times this month do I need to see them? If you're admitting them on the first of the month, then yeah, we can see them at the end of the month and do the catheter change, because that's almost 30 days. But if you're admitting them on the 15th and you're changing the catheter on the 15th and they don't need to be seen until the 15th of the next month, how many more times this month do they need to be seen? None. So the start date of your monthly order will be the first day of the next month. So always keep in your head, when you are writing a frequency order, if you're writing a daily order, the first thing you should think of, how many more times today do they need to be seen? If you are writing weekly orders, how many more times this week do they need to be seen? And you've got to be conscious of where you are in the week. Think today is Wednesday, they got to be seen at least Friday again, so that's at least 1 time this week. So you would start 1 week 1 and then whatever after that. And again, monthly. If you're seeing them on the 1st, then yes, we could see them by the end of the month to do a Foley catheter change, because that can be within 30 days. But if you're seeing them on the 15th and they don't need to be seen until the next month, then you have to change the start date to the next 1st of the month. If you ever have any questions, if you ever have any doubt, you do have your little blue folder of, quick tips, guides, reference guide, this is how you do this, in that blue folder. If you do not have a blue folder, if you have lost your blue folder, please let us know and come and get a new one. It literally will walk you step by step what you need to do. It tells you, okay, I've done the start of care, I've got to do this, 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 and this. I've done an initial evaluation, I've got to do this, 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 and this. It'll also tell you, this is how I put the orders in. Resumption of cares. It will tell you in there, resumption of care orders go in as verbals. There is a section on orders that says, if it's a medication, it goes as written. If it's this, it goes as this. And it will tell you. And then there is a small frequency tip that tells you, I'm writing a new frequency. Did I discontinue the previous one? And how many more times this week? How many more times this month? That blue folder is an awesome tool, and I encourage you strongly to use it. Especially if you're brand new. If you're brand new to home health, if you're brand new to this company, if you're brand new to Bright Tree, this is that little step guide. If you've been with a company forever and you've been doing Brightree forever, it still doesn't hurt to look at that guide, because you're going to have very busy days. And I'm sorry you're going to have busy days, but I also know you have very, very light days. And you're going to have very busy days. And I'm sorry, even I will have a very busy day, and at the end of the day think, oh, I'm done, and close everything out. And then the next couple of days, I'm like, oh, crap, I forgot to do this. Just pull the guide out and say, okay, I did a start of care on Mr. Smith. Boom, boom, boom. Yes, I did all these. I'm good. I've done this on this person. Boom, boom, boom. Yes, I'm good. And just a quick visual check. It doesn't take any, it only takes a few minutes. It's a peace of mind for you that you're done. You're not going to get a phone call from one of us in the office saying, why didn't you do this? You did this wrong. It helps you keep a peace of mind. And it's easy to just have the folder sitting there as you're doing your documentation, as you're writing your orders and everything, to just quick reference. And if you're looking at the guide and you're trying to figure it out and it doesn't make sense, or you just can't figure out how to do something, that's what we're here for in the office. That is what Jen is for. That is what I am for. That is what Melanie is for. You've got team leaders. You can call Amanda. You can call Garth. You can call your other nurses. If you know, oh shoot, Christina does this and she always does it really well, and I can't figure it out. I'm sure as long as Christina's not in the middle of a gazillion things, and you just give her a quick call, all of the nurses, all of your fellow clinicians, anybody, if you call them and say, I just can't figure out how to do this. How do you do this? 99.99999% of the time, they're going to be like, oh, well, you do this, this, and this. And we'll help you through it. We will talk you through it. And if we truly can't talk you through it, or we can't figure out because you're sitting at, McDonald's trying to chart and we can't see your screen and we can't figure it out, we may ask you, hey, pop in whenever you get a chance and we'll help you fix it. Sometimes we actually have to visually see the screen to see what's going on. Again, I would much rather have you call me. Call me. How do Dave, I'm trying to do this and it won't let me. I'm trying to do this and I can't figure out, this is what the new frequency is going to be. When should I start it? How should I do it? I'd much rather you call me at that point as you're putting it in, instead of you thinking, oh, well, I don't, I'm not exactly sure how to do it. So you just do it and submit it. And then we get the order a couple of days later and it's like, oh crap, it's a total mess. And us have to call you and say this. Call us, just call us, anything. And this isn't just for orders. That's what we're here for. We are your support. We are your main support. Your other clinicians are your support. You're not seeing these patients by yourself. You may be the only one in the house. You may be the only one touching this patient, but you're not technically alone. Because you can pick up your phone and call us at the office. We'll help you. You can pick up your phone and call another clinician. Say somebody saw him in the morning and you're seeing him in the afternoon and something doesn't look right. Call the other clinician. We're all your backup. And I know I strayed from orders into everything else, but this will help you with orders. If you can't figure out an order, call us. We're your backup. But at anything, call us. We're your backup. So just to recap real quick, plan of care orders, only to be done at start of care and recertifications, because they go on a plan of care and they get signed that way. If you do a resumption of care and you put the order in as a plan of care and it's the middle of the cert period, there's no doctor signing that. It doesn't go to get a doctor's signature. So we are technically working under an order with no doctor's signature, and we can't do that. So just be mindful. And if you have any questions, because sometimes you're doing a resumption of care and it's within the patient's recertification window, that can get confusing because the book says if it's a resumption of care, do it as a verbal, but if you're doing it as a recert, you should do it as a plan of care. That gets very confusing. Call one of us. We will help you through it. We will explain this is why you're doing it this way. But the general rule, plan of care, or start of care is recertifications, plan of care. Only exception is if they go in the hospital, those discontinued orders go in as plan of care. Written orders, medication bottles, a script that was handed to you the wound care orders, the home choice partners orders, the doctor's orders that come across to say, I want, physical therapy to continue. Any of that with a doctor's signature, not nurse practitioner, doctor's signature on it, go in as written. And the majority of those do come from the office. We're putting those in. But the medications, if they've got a bottle and it's got a drug on it and it's got where the doctor came from, that goes in as a written. That in your hand is the written order. Verbal orders, again, if you verbally communicated with somebody and they gave you direction of change. And again, you've got to think about resumption of care order should be verbal because you've resumed the care. You should have called the doctor and said, I have resumed the care. Nursing is going to see 3 times a week for CHF teaching because that's what they keep going in the back of the hospital for. And then write the verbal order and who you spoke to. Physical therapy calls and says, okay, I just did a reassessment. They really could use 3 more weeks of therapy at this to do this. That's a verbal order because you verbally communicated and somebody said that would be fine. Again, write on the verbal order, read back verbal order from so-and-so. Put the person's name on it. And that should be it. Again, that blue folder is golden. It has everything that you need to know and tells you how to do everything. All of us here in the office, all of your fellow clinicians, call us if you have any questions or concerns. The word again was ambiguity, and I don't know. I think I've used it before, but who cares? I'm just going to be ambiguous about it. All right, everybody have a great day. Remember, we're here to back you up. Thank you for everything you're doing. And I know a lot of things keep changing, but we're trying to keep you up on it. So call us if you have questions. Everybody have a good day. Bye.